Good afternoon, I think. Good afternoon to all the dignitaries. And at the outset, I would like to thank my teachers, Dr. Kumar sir, Vijay sir, Vanita ma'am here, and Amit sir, and the entire organizing team for this opportunity. I think today I'm supposed to be talking about the adjuvant Pembrolizumab in patients who have received standard adjuvant treatment in stages 1B to 3A. So this is the Keynote 091 study, which the abstract was presented at ASCO 2022, and this is published in the Lancet Oncology 2022. The main member was the Mary O'Brien. So what was the idea? We all know that after the resection, the stage 1B to 3, the recurrence rates are usually approximately more than 30 to 40%. So our aim as oncologists was always to improve the survival in these patients. So we have had a lot of session today about the adjuvant TKIs and what to do for further, and we have a lot of unanswered questions. So this is again going to be an unanswered question again. So looking at the usage of the adjuvant Pembrolizumab in patients who have completed the standard adjuvant treatment. So this enrollment was done in 3 parts. First was the registration, so where you could confirm stage 1B, where T size was more than or equal to 4 centimeter, and stage 2 and stage 3A NSLC according to AJCC criteria. Patients who underwent complete surgical resection, that's R0 resection, and there was a provision for tumor tissue for PD-L1 testings were enrolled. After which the PD-L1 testing was done by the IHC 22C3 PharmDX, and then patients were eligible for randomization included that there was no evidence of disease after surgery. They were in a good performance status of 0 or 1. And all patients who required adjuvant chemotherapy had to receive adjuvant chemotherapy, and the maximum cycle was limited to 4, and stage 1B was restricted at the physician discretion. So they were randomized in 1:1 manner with Pembrolizumab 200 mg 3 weekly for less than or equal to 18 cycles, or placebo 3 weekly was given. So this study had dual endpoints. So one, they looked at the DFS in the overall population and also the DFS in the PD-L1 TPS more than 50% population. The secondary endpoints included the DFS in the PD-L1 TPS more than 1%, overall survival in the overall population and the PD-L1 subgroups, lung cancer specific survival, and safety. So all the groups we could see here, so you had approximately around 1177 patients, and patients were equally distributed in all characteristics in both the groups. Be it age, the median age was around 65 years, the gender was equalized. When it came to the geographic region, the Western Europe were more in number, but they were again stratified equally in both the groups. And be it smokers or with the histology, and at least around 85% of the patients received adjuvant chemotherapy in all the groups. And stage 2 was the most common pathological stage in all these groups. And coming to EGFR at the input, no. Whether there was difference in the safety, no. Whether there was difference in the exposure to the drug, so whether it was in terms of adjustment of drug dosage or interruption, so there was not much difference. So they said, why is this different? You expect that when a PD-L1 is higher, you expect the immunotherapy to be working higher. But then probably what they looked here is the placebo arm actually overperformed than the PD-L1 group. So that was actually the reason. But PD-L1 did fare better, but the placebo group did fare higher than expected. So that was the reason why this was not significant. But yes, they'll have to look into other unknown markers, like where you do not know what are the other markers which are going to be, which has given significance in the placebo arm. So that was one interesting thing. And this overall survival data in this is still immature, so there was nothing much to discuss there. So this is and when compared to the safety, when coming to the safety, there were no new warning signs in the safety also. And then they assist in the non-pre-specified subgroups. So these non-pre-specified subgroups, where they could see whether it impacts the type of surgery or histology, did not favor much. But whether we really need to consider this, because it was not a pre-specified subgroup, question mark again. Study probably at this stage of point is just is just going to be warming us in future that whether adjuvant pembrolizumab could be used to increase the survival in all patients who have resected lung stage cancer. So with this, I would like to thank you and wishing all of you a Merry Christmas and an advance Happy New Year to you.